Hello and welcome to this mini-gem, brought to you by the Association for Elderly Medicine Education. My name's Frances Tanner and I'm going to be discussing Do Not Attempt Cardiopulmonary Resuscitation Decisions. I hope that by the end of this mini-gem you'll be aware of both the risks and benefits of CPR and be more aware of when, how and with whom to have discussions about this. So, there's obvious benefits to performing CPR, and in an average UK hospital, between 15 and 20% of patients will survive and be able to leave hospital afterwards. Unfortunately, the chance of this happening is lower if you have a cardiac arrest outside of hospital. But it is really important to remember that these statistics include all patients receiving CPR, and an individual person's chance of surviving can vary dramatically. So, with this in mind, it's important that you know what the risks of CPR are in order to be able to make these decisions. Rib and sternal fractures are really common during CPR, and the force of CPR can also cause the liver or the spleen to rupture. The majority of patients that survive will need at least a brief period of observation in either a coronary care unit or intensive care. And if your patient gets admitted to intensive care, there's a high probability that they'll require artificial ventilation initially. Some will also go on to need dialysis or inotropic support, and sadly, permanent brain injury from hypoxia can also occur during cardiac arrests. This risk is higher if there's a delay in initiating CPR, and some people also deem CPR to be an undignified way to die, and because CPR is the default position, if you don't have discussions with patients in advance of arresting, you run the risk of patients being treated against their wishes. So, in order to prevent this happening, it's really important to have discussions with patients in advance. Often the best way to do this is whilst the patient is still relatively stable, so that they can fully participate in these decisions. And bringing up CPR in the context of wider discussions about what the person would wish when they begin to reach the end of their life can be a more natural and holistic way to approach this. Often people will feel more comfortable if they've got someone close to them during these discussions, but you need to make sure that the patient consents to this. An ideal person to lead these discussions is a health professional who knows the patient and their situation well, if they've had appropriate end-of-life discussion training themselves. But this isn't always possible, and you must remember that initiating discussions is the responsibility of the whole team. So, there will be situations where you won't be able to speak with relatives. In these situations, DNACPR decisions should not be delayed because of this. An example of this is in an emergency when a patient's at imminent risk of having a cardiac arrest. In this situation, it's really important that a decision is made about whether CPR would be appropriate for the patient. Don't delay making this decision in order to speak with the relatives. However, at the earliest opportunity, when it's feasible and safe to do so, you should then have a discussion about any decisions that have been made. Similarly, when you're unable to contact relatives or legal representatives for whatever reason, don't delay making the decision, but do document all the steps you've made to contact them. So, the Resuscitation Council suggests that you ask yourself, is this patient at risk of having a cardiac or respiratory arrest in the foreseeable future? If you think that this risk is low, there's no need to discuss CPR with the patient unless they wish to do so. But if you think the risk is higher, the next step is to make an assessment of whether CPR could be successful for the individual. And this assessment should be performed by an experienced senior clinician. When CPR is deemed unlikely to be successful, this is normally multifactorial in nature, but factors that can influence a DNA CPR decision include when a patient has an incurable condition, such as terminal cancer or severe heart failure. Remember that when patients are in the last days of life, they have almost no chance of successful CPR, and therefore it would be inappropriate. A patient's comorbidities and their current clinical conditions, such as overwhelming sepsis, can also influence these decisions. But it's really important that prejudices such as basing a DNA CPR decision purely on age or disability do not occur. Similarly, your own personal opinion on a patient's quality of life should not enter into these decisions. And blanket policies such as all patients in nursing homes should not be for CPR should not occur. But If after careful consideration CPR is deemed to be medically futile, you should record a DNACPR decision. A recent landmark court case involving the Tracy family ruled that doctors cannot be forced to perform inappropriate CPR, but the court did make it really clear that when a decision is made not to perform CPR on medical grounds, that the patient, and if they consent, those close to them as well, should be informed of this decision. The court ruled that to not do so infringed on a person's autonomy and human rights, and it was considered that the only situations where this information should not be delivered to the patient is if you think that telling them will cause either significant physical or psychological harm. Similarly, if a patient lacks capacity and they have a legal representative, you must inform them of any DNACPR decisions made. Sometimes patients will disagree with the medical decision about this, and that's okay, but it's good practice in these situations to offer a second opinion. But as already discussed, you cannot be forced to perform inappropriate CPR. When patients do have a suitable chance of surviving CPR, it's important to ask them if they want to be involved in this decision. If they do, you'll need to discuss the risks and benefits of CPR with them to help them make an informed decision. But sometimes patients don't want to be involved in these decisions, and you need to respect this. Ideally, if they consent, you should discuss with those close to them to get an idea of what would be in their best interests. But ultimately, when patients don't want to be involved, the consultant or GP is ultimately responsible for making a decision in this situation. When patients don't have capacity, but are at risk of having a cardiac arrest in the foreseeable future, and you think this could be successful, first of all you need to look for an advance directive which is valid. If they have one, you must respect this as it's a legally binding document. But if not, check to see if they have a legal representative, such as a guardian, deputy or welfare attorney. If they do, consult with them, but if not, consult with those close to the patient. In both of these situations, the discussion should guide the decision making, but ultimately the GP or consultant are responsible for acting in the patient's best interests. So, I hope that following this mini-gem, you're more aware of the risks and benefits of CPR, and also of when, how and who to involve in discussions about it. Don't forget that in emergency situations, decisions should not be delayed in order to discuss with relatives. All the information in this mini-gem was based on Resuscitation Council guidance, which was updated in October 2014. Thanks a lot for listening.